here's a patient that came in with chest pain and has sort of this, again, so it's not always easy to tell, but very thin hyperattenuation, crescentic focus in the aortic wall and some displacement of the intimal classification. Remember, with the aneurysm, the classification should remain like this one. It should remain peripheral. The patient had a contrasting time CT at that time, and again, there's an intramural hematoma there. I just want to make the point one last time. If we didn't do this pre-contrast study, you would just call this a thrombosed aortic aneurysm and you would completely miss this. This patient came in 1 week later, and you can see has developed a frank dissection in the aorta. So that's one possibility. They can regress or they can progress to dissection or even aneurysm. Another example here, pre-contrast study, right attenuation in the aortic wall, medially displaced aortic classification, intramural hematoma. In this patient, the intramural hematoma has ruptured, and this patient has a lot of blood in the mediastinum and a large left pleural effusion. Again, the classifications for the intramural hematoma, just like with the dissection, they're displaced centrally. And I think I made that point clear, so I don't need to show you all those cases again. But in the interest of time, I know you guys have to go somewhere, we can just skip through these. The point is that do the pre-contrast study because you can't always tell the difference between. Sure.
So when we order our CTAs, does that automatically get protocol?
Yeah, automatically.
Non-contrast and then the contrast?
Yeah, that's why again the history is important. You have to really specifically state what you're concerned about, right? If you tell me you're concerned about aortic dissection or aneurysm or whatever, then the pre-contrast study is part of a standard protocol. Okay? Good. Any other questions? Very good. So let's talk a little bit about the penetrating aortic ulcer. Right? This is something that is a consequence of severe atherosclerosis and disease in the intima. These patients tend to be older, so we can and have a lot of plaque burden in the aorta. You can see here that there's an atherosclerotic plaque that ulcerates and eventually erodes into the media. And then again, it's the same thing happens. You have pressurized blood that can enter the media and cause aneurysmal dilatation and cause a dissection and intramural hematoma. They tend to, for some reason, involve descending aorta, one of the other portions of the aorta. And of course, hypotension is a common denominator in almost all of these disease entities. So again, clinically, it's not going to be easy to tell. In fact, it's virtually impossible to tell the difference between these three entities. They have the same risk factors, they have the same symptoms. CT is really the only way to go. 90% of these patients are hypertensive, and they tend to be on the older side. They commonly involve the descending aorta, rarely the ascending aorta. So we can see here, we have a very irregular, you can see it's a very tortuous aorta, something that's very common in these older patients. And you can see it's sort of like a little projection of contrast that's gone beyond the lumen of the aorta. And there's a little intramural hematoma associated with it. So you can see here, here's intramural hematoma. And it's really important to look at the sagittal chronos too, because the axis can be misleading. You may want to pull out a dissection because you see a line through it. But if you look at the sagittal, you can see that what you're cutting through here is actually a portion of the intramural hematoma that's associated with this penetrating aortic ulcer. Another example here, we have, again, a lot of atherosclerosis in the aorta, and this little sort of irregularity of the aortic wall, and a little projection of the contrast distal to the expected location of the lumen, and it's associated with some intramural hematoma as well. This is a penetrating aortic ulcer. And like I said, they're all treated the same. So if this was in the ascending aortic, patient, it will be treated surgically. If this is in the descending aorta, it will be treated medically. Another example here of the aortic arch. You can see this nice little, well not nice, but this little protrusion of contrast coming off the arch, which represents a penetrating aortic ulcer. And there's a small hematoma that's associated with it. In this patient, it's a very obvious ulcer here that's coming off the arch, which is with a large hematoma. This patient came back some years, because this is going to be managed medically, remember, because it's a type B. It's distal, it's not involved with the ascending aorta, so it's going to be managed medically. And 19 months this patient came back, there's a slight interval increase in the aorta, and now the ulcer is larger as well, okay? So those are the penetrating aortic ulcers. So I have like 3 more cases to show you, then you guys can get out of here. And this is something that we see quite often. What is this? This is a PE, bilateral saddle emboli. When you have a large cut, it predisposes the patient to subsequent heart issues like pulmonary hypertension. And the question is, how can we tell pulmonary hypertension on CT? There are a few things that we look for, right? So looking at the heart, we can see here that the right ventricle is quite dilated, right atrium is dilated, so the patient probably has some element of right heart failure going on. The septum here, which should be either straight or slightly bowed to the right because of the lower pressure, is actually bowed to the left, and there's a significant decrease in the size of the left ventricle. So when I see this and I see that, I suggest the possibility of pulmonary hypertension associated with that clot. Another example here, you can see a large clot, bilateral clot, saddle emboli, and you can see the septum here is rather straight, and the left ventricle is significantly reduced in volume and in caliber, compatible with pulmonary hypertension associated with this clot. And some other things that we can see as well, which is not always reliable, is reflux of contrast into the hepatic veins. That doesn't always happen, but that's something else that we can look for. And the last case I have to show you is this patient, which is a 65-year-old female with abdominal pain. And what do you see? Right, somebody said that there's a thrombus in the SMA. You can see here. Here is a normal enhancing vessel, and there's this low attenuation in the SMA, and what is associated with that? So this patient is developing what? Ischemic colitis, because we can see they're thickened, small bowel loops with enhancement of the mucosa. There is a lot of fluid around it. There's interloop fluid, which is suggested when you see in mesenteric ischemia, is stranding of the fat in the mesenterium. There's a lot of fluid in the abdomen. So this patient has an SMA thrombus with the development of mesenteric ischemia. Okay, any questions? So I tried to show you guys a variety of this, one more. Right here, this is an example of renal infarct and artery thrombosis. You can see normal enhancing left kidney here, but the right kidney here is markedly hypoperfused. And if you look carefully, the aorta is irregular atherosclerosis, and the right renal artery has a significant narrowing here, or stenosis, or thrombus caused by atherosclerosis, and is affecting the kidney. So this is an example of renal artery thrombosis with an associated infarct. So I tried to show you a bunch of diseases that relates to cardiovascular complications, various things that we see commonly. Acute aortic syndrome, remember, involves 3 entities mainly, and 4 if you include the rupture of the aneurysm. Aortic dissection, intramural hematoma, penetrating aortic atherosclerotic ulcers. Clinically, you can't tell a difference. I don't think so. Tell the difference between these 3. CT is really vital, and with CT we must do a pre and a post contrast study, or else we would miss this very important intramural hematoma. If these entities involve the ascending aorta, they're treated surgically. If there's no involvement of the ascending aorta, then they're treated medically. And also, we talked about aneurysm. That should be an example of fusiform aneurysms, sacral aneurysms, myocardial aneurysms. We did talk about trauma. And then briefly, I showed you cases of pulmonary embolism, organ infarcts, and mesenteric ischemia. Any questions? It's a lot to digest, I know, but hopefully it was useful. Any questions?